Welcome to Season 4 of My Wife the Dietitian, a fun, evidence-based weekly podcast about nutrition and healthy living.
On today's show, we're talking to pharmacist Dr. Dean Elbe, creator of the online resource called Drug Nutrition Interactions. Dean answers all our questions about how our food interacts with the medications we're taking. We learned a lot on this episode. It's a good one. Stick around.
Enjoying the show? You can help others find it and enjoy it too by giving us a 5-star rating or review. If you feel like reaching out to us with a question or comment, you can send us an email at mywifetherd@gmail.com. And don't forget to visit our website at mywifethedietitian.com, as well as our social media pages. We're on Facebook, Instagram, and YouTube. Enjoy the show. Welcome to My Wife the Dietitian. Hello, Sandra.
Hello, Rob.
How's it going?
I'm excited.
You're excited?
Yeah, we're interviewing someone I've known for over 28 years. On my first job after dietetic internship, I worked with Dean Elbe, pharmacist at Richmond Hospital. And it's so amazing, all the work he's done. And it's so cool to talk to him about this incredible resource that he's developed for dietitians and other healthcare professionals called drugnutritioninteractions.com. And it's basically an online version of a handbook that all dietitians had as they worked in their clinical job, looking up different medications that people were on and the food and nutrition interactions. So it's a pretty amazing resource. The conversation goes from GLP-1 weight loss medications, caffeine, the easy hello and tough goodbye with PPIs, and grapefruit medication interaction, the barbecue risk, hormone replacement therapy. This is a rich conversation.
Yeah, there's lots going on in this one. Dean really knows his stuff, and he's got lots of great stories. So it's not just like information overload. He knows how to explain things in a way that you'll understand and it'll stick with you. So
and be entertaining.
yeah, we have some fun like usual. So it's definitely worth listening. We learned a lot. There's a lot of like eye-opening information that
moments for me too.
Yeah. So. And that's why we want him to have him back as our resident pharmacist on My Wife the Dietitian
for question and answers for people that have any questions about their supplements, about medications they might be on, and foods that they might be eating, and what are the interactions.
Because it is a bit complex, and we want to help people understand this so that they feel comfortable eating and doing what they need to do to live a healthy life. So, without further ado, let's get to this pharmacy guru. Stay with us for Dr. Dean Elbe.
So it's our absolute pleasure to bring you Dean Elbe from BC Children's and Women's Hospital today, and someone I've known for 28 years. And it's so awesome to have you on the show today, Dean. Could you tell the listeners a little bit about you and who you help in your work?
For sure. Yeah. Thanks for having me on, Sandra and Rob. Yes, I'm a clinical pharmacy specialist in child and adolescent mental health at BC Children's Hospital. So I work with children and youth and their families with mental health concerns, with mood disorders, psychosis, autism, other conditions. Anxiety disorders are very common, of course. And so that's my day job for sure. And then my other work that I think kind of the way we met, although we worked together at Richmond Hospital some 28 or so years ago as we were recounting, is that I've been working on this project on drug nutrition interactions or food medication interactions like throughout my career. Even before I finished pharmacy school, I was working on this topic, and I've sustained and worked through this all the way up to the launch of our website.
That is so awesome. And I have one of the original, there was so many iterations of the actual, like the food and medication interaction book and you worked with the dietitian.
Which edition do you have? Do you have it there?
I have it in front of me. It's the 10th. And it's like,
oh, wow.
I had it in internship because my maiden name's on there, Sandra Innes. So
Wow,
it's like, that's old. Yeah. 1998.
1998. Oh, I got up to the 19th edition was the last edition of that book, which published in around 2018.
Wow.
So we'd always hear like people come up to us at conferences and they're like, oh, I have that book. It's orange cover. And we're like, that is 25 years old.
That's right.
Oh, man.
That's my other one. Well, this is the thing, to have it online, that it just makes sense because the paper and the books become outdated pretty quickly, especially if we're talking about medication, right?
Oh, there's so many updates. I learned how frequently the updates occur during this project. Basically every day, Health Canada and the US FDA release updates of new warnings. New drugs come out all the time. And so, once it's in print, it's essentially out of date with the speed that things are changing.
It's even in this book, there's one page that it says in big letters, like you guys published it, and then it's like, warning, been withdrawal from the market. So like, I didn't write that, but I think it was because you probably, just as you were printing it, you had to like, oh, this one's updated. Like it just updated between the publish and printing. It was just interesting. So you can tell how quickly things come and go and off the market, and like, it's just incredible.
Yeah.
Is there any rhyme or reason to why things are changing? Is it just more information or changes in other factors that are affecting these interactions?
A couple of things. So sometimes new studies come out, or new, drug companies will certainly seek to find new uses or indications for their medication to have more people taking it. But also there's a continual flow of post-marketing reports of adverse reactions and warnings that arise from those reports. And so periodically companies will go back and they'll list new side effects that were identified in the post-marketing period. And then if there's new warnings coming out of that, they'll update the labeling accordingly. So there's sort of an incremental change for a lot of different medications. I'd say, newer medications, you might see an update yearly. Older medications that have been on the market for 5 or more years, you might see an update every 2 or 3 years.
Right.
And then some medications, some of the cancer drugs, they're getting so many new indications. Some of these, what we call immune checkpoint inhibitors, treat like 30 different kinds of cancers. So every time they add a new cancer that has evidence that they treat, they update the label to reflect that.
Gotcha.
And so those ones change a lot.
Wow. Yeah. And I remember I was listening to another podcast with you being interviewed recently. And one of your other roles this is so cool, is because of your experience, and you've been in the field for 28 or 29 or 30 years, right? Because we've known each other since 1997.
Let's call it 30, yeah.
30, right, exactly. After you graduated from UBC, and now you have your PhD, right? Dr. Dean Elbe.
PharmD, Doctor of Pharmacy, yeah.
Yeah, okay. But you train new psychiatrists in BC that are seeing children and like adolescents and teens. Is that right?
Yeah, it's a really cool opportunity we had here. We have a child and adolescent psychiatry fellowship for psychiatrists that want to do extra training and specialize in child and adolescent psychiatry. They do an extra 2 years of training at the end of their residency. And it became its own specialty in around 2016. We had this training program developed, and one of the first psychiatry residents asked if they could train with me for a month to do some extra, brush up on their medication knowledge before they go into practice. So we thought, well, let's try this. And it worked out really well. They got a lot of value from it. And so now I pair them when I teach pharmacy residents. They come and do a month rotation with me. I also take a psychiatry resident at the same time. And I just finished, I think, rotation number, I want to say 22 with a psychiatrist earlier this month. And it's become basically an established part of our program that is kind of unique and is a draw for other for psychiatry residents actually to come and train at UBC and BC Children's. And it's been super rewarding. It's great for my pharmacy residents to have a psychiatrist on tap for a month. And they learn so much about the diagnostic considerations and the things they think about. They teach the psychiatrist like resources and where to find drug information. And they really walk in my footsteps for a whole month doing all the things a clinical pharmacist would do. And they seem to love it. So, yeah, so it's really
it helps
unique.
that they have a good mentor. I think that's a big part of it, team. Oh my gosh.
Yeah, for sure. It's been a great experience. I've loved teaching the pharmacists and the psychiatrists with me.
Yeah. Oh my gosh. Yes. And, it's funny. I dug up this old BC Pharmacy magazine, the magazine of the BC Pharmacy Association from March 1998, because you and I both wrote articles in there. Mine was on like liquid nutritional supplements, like, different energy drink. Well, not energy, but Boost and Ensure and those kind of pharmacy. And then yours was on the grapefruit juice drug interaction, because weren't you on the cutting edge of when that all came about?
Yeah. So when I was an undergrad at UBC, my summer job was to work on the Reference Guide to Drug Nutrition Interactions for the BC Diet Manual. Right. So that was sort of the entree into this food medication interaction, drug nutrition interaction world. And I remember vividly going to my interview with this pharmacist, and he had this article. He says, like, take a look at this. It was grapefruit, and it was a very short piece in the Lancet journal about how it interacted with a blood pressure medication called felodipine. And I remember, the story was that they had tried to mask the taste of the alcohol with the grapefruit juice and gave people the blood pressure medication, and the blood levels of the drug rose in both the people that got alcohol and grapefruit juice, but also in the group that got grapefruit juice alone. And so they figured out, there's something here. There's something in the grapefruit that's causing the interaction, not the alcohol. And that was the genesis of this discovery, essentially, of how grapefruit affects medications. And then the journey began. And so that had happened just as I was doing that manual. And I found it really fascinating. And I decided to stick with the topic.
With the drug nutrient interactions.
Mm-hmm. And I taught myself web design by creating a grapefruit drug interaction website. And I thought, well, I might use it and like 3 people might see this, but I'm going to teach myself web design. And,
3 people, yeah, right.
And more people than I thought saw it, including the dietitian who wrote the food medication interaction books. And she actually contacted me because of that website and got me involved writing for her book, first on grapefruit drug interactions, and then taking on more and more tasks with her book, eventually leading to culmination of me authoring the last 2 editions after she passed away.
Right. Because she passed away in like 2011 or something.
Yeah, that's right. Unfortunately.
Yeah.
But like, what a journey from like, somebody might see this to, hey, I'm, now the author of this book.
Totally. Yeah, oh my gosh. And it's a resource. We'll have it linked in the show notes for people because it's such a great resource for looking at, like, if you're taking a medication and you need to know, what it interacts with and when you should take it and what might be affected in your lab work and like other, like even like looking at this grapefruit juice, and like all of these different interactions because of the different mechanisms of action of the medication. So it's just, it's such a wealth of information. And as you said, with like being online, you can keep it updated more than the paper, the book.
Yeah, I go literally, if not daily, I go weekly to the FDA website and the Health Canada website looking for new updates and newly approved medications, and can rapidly incorporate them into the website. So it's always up to date.
Yeah, my gosh, that's a lot. Yeah. Wow. And I remember just listening to another interview that you were doing about the fact that like the different types of fruit, like Tangelo and Seville oranges, like they all have, like some are similar in terms of the interaction. Is that right?
Yeah, I learned a lot about citrus fruit, a lot more than I thought I would ever know about um, yeah, so it is. So certain components that have this certain chemical, and the name of the chemical is this big chemical name, 6,7-dihydroxybergamotin is the
wow.
chemical that causes these interactions. You might know bergamot in Earl Grey tea and that sort of orangey, grapefruity kind of essence, bergamot. So that's where the name comes from. But that's the chemical that's in there that inhibits drug metabolism that causes these drug interactions. And so it is found in grapefruit, but also in pomelo, which are those giant grapefruits with the big rind. And it turns out grapefruit is actually a hybrid of pomelo and regular oranges.
Oh, really?
So pomelo was the original one, and it's even sometimes more bitter than grapefruit. And then grapefruit, some of those lumpy oranges called Seville oranges that we use to make marmalade, those have high concentrations of that chemical as well. Tangelo, that's a hybrid between tangerine and pomelo. And so it has that chemical, certain species of mandarins, but not everything. And then the good news is sort of Valencia and navel oranges don't have that chemical because they don't have that bitter flavor, essentially.
Wow.
And see, I told you I know a lot about citrus fruit.
Holy.
And so eating pieces of the fruit, eating extract, or drinking the juice of all those fruits contains that chemical and can lead to drug interactions.
Wow. And it's specifically related to blood pressure medications, isn't it? Because I know my dad has heart issues, and he's 92, I think now. So he's had some issues for 40 years now. And the grapefruit thing has been part of his, he's had to be aware of that for years now. So I've kind of been aware of that as well. So
certain blood pressure lowering medications, mostly what we call the calcium channel blockers. So felodipine was the first one that was discovered on, and then some medications like it. But it's actually more than that. It's there's immunosuppressants, there's psychiatric medications, antipsychotic drugs, some cancer drugs. There's probably 85 to 100 different medications that have labeling or studies that say they should be avoided with grapefruit juice.
Really? Wow.
Due to clinically significant drug interactions. So yeah, it goes beyond the blood pressure lowering drugs. Yeah. And it's not all blood pressure lowering drugs. And it's not all calcium channel blockers either. It's certain ones. So yeah.
And different reactions with all of those different scenarios, I guess, like it just is a different catalyst kind of?
Most of the time it's inhibiting their metabolism, so you get higher than expected blood levels of the drug and you get more clinical effect and then more side effects. Very occasionally it's a lowering of blood levels through a different mechanism, but most of the time it's pumping up their absorption beyond what is expected and the consequences of that.
And is the goal to kind of get to from a science perspective, is the goal to kind of get to a point to sort of see exactly what the cause kind of is? Do you know what I mean? You see sort of the symptoms and the results of this interaction, but has anyone kind of pinpointed what the initial cause is? Do you know what I mean?
Yeah, especially when that first came out, right? Everybody's like, wow, look at that. We don't know why it's happening. We've observed it. We now need to try and figure out why. So there was a flood of research following that initial publication in The Lancet. It was 1991. And that's why I started to produce the website at the time and keep up on the flood of research. So people were trying all sorts of different medications and they're trying to figure out what was, how this worked. And they eventually discovered, okay, well, there's certain enzymes in the small intestine. We normally think of them being in the liver, but they're actually metabolizing drug before it's absorbed. And that certain chemical that I mentioned, the 6,7-dihydroxybergamotin, they figured out was the chemical that blocks those enzymes. It binds to those enzymes and doesn't let go. And that's what slows down the metabolism of certain drugs. And then we were able to work out, well, which drugs are going to be likely affected. And we can now with some confidence say, well, if it's metabolized by this certain enzyme system in your liver called CYP3A4, that's where you're likely to see an interaction with grapefruit juice. There's a couple of other factors that are at play there. But if there's a lot of metabolism through 3A4 going on before the drug is absorbed, that's a pretty good bet you're going to have a drug interaction with grapefruit and related fruits.
Wow.
Technical explanation, but that's the explanation.
Yeah, that's awesome.
I have a personal story about this because I think it was about 20 years ago. My parents, my dad just retired, and I think they went to Florida, like my parents, and they were renting a place, and there was a grapefruit tree on their front lawn.
Yeah.
So he was having probably 3 or 4, maybe 5 grapefruits a day, just like it was fresh, and just loved it. And he was feeling really lightheaded and didn't know what was going on. And he was on a blood pressure medication. And so when I think he, I don't know, ended up talking to a pharmacist or something, and they said about the interaction with grapefruit juice. And are you eating any grapefruit or take? And he's like, yeah, I'm eating like 3 or 4 a day. Like, well, that's probably what's happening for you. And then that was a light bulb for him. And
that is so classic. Such a classic description because it's on the trees and people have all this fruit. Well, I got to use it up.
And it tastes so good.
And who would think fruit is a danger, right? It's not one of those things that you think would ever give you any issues health-wise.
Right. Yeah. And it took many, many years after that initial discovery for it to sort of become, somewhat common knowledge amongst health professionals. Like they kind of say it's about a 17-year delay from research to practice.
Yes.
And so it was 1990. There was an early report in 1989. The first publication was 1991. And it was 2006 when the big Canadian drug book, the CPS, had a table and a section on grapefruit drug interactions for the first time. So there's your 17-year gap.
17 years. Oh my gosh, that's incredible. And then there's a lag in the marketplace because as with you and Elizabeth, dietitian, on the other podcast interview you did recently, there is hardly, like, people don't drink grapefruit juice very much anymore. And I don't see it really on the shelf as much.
They're all afraid of it.
Yeah, well, I mean, you can tell it's having an impact when I go to the dietitians conferences in the US. Yeah. I remember seeing there was a lobby essentially, or a marketing board from Florida trying the angle of grapefruit. It's not so bad, essentially. And like, look at all these medications that don't interact with grapefruit. And you can tell it was affecting their sales, right? And since then I've seen them trying to develop grapefruit that doesn't contain this specific chemical. Like they were able to do it in a lab setting where they could extract that active interacting component and still have grapefruit juice that tasted the same way. But they said the cost of producing it is prohibitive. But yeah, so it's affecting grapefruit sales for sure. And the industry has noticed, let me tell you, they're aware.
Yes. Oh my gosh.
But like a lot of diet, I'm sure you must have noticed at different facilities and hospitals, like grapefruit is no longer they just took it off the menu essentially, right? So it can't, it can't cause interactions essentially.
Yeah, because that would just be a lot of work for looking at every, you do it anyways individually, every client or resident or patient and see, okay, where they, what's medication they're on and like, what do they need to do in their diet? And I mean, if it's like you said, 100 different medications, then that's just an easy one to remove.
I remember somebody brought a fruit basket into one of the inpatient units here early in my time here at Children's Hospital, and it had 2 giant pomelos. I'm like, nope, I'm taking those away.
I'll take those home and eat them.
Yeah.
That's hilarious. Yeah. Oh, totally. Oh my gosh. Wow. And I actually have questions for you, but we're like, they're just, I knew that this would be jam-packed with a great discussion. Okay.
You can really go down the grapefruit rabbit hole.
Grapefruit hole. That's right. Totally. Oh my gosh. So I was wondering, so for instance, I mean, I get this question from clients all the time about their supplements. So can my supplement interfere with prescription medication? And could it actually make, the medication work either less effective or increase side effects? I know it does with grapefruit juice, but what about different supplements?
Yeah, for sure. That is one of the sections in the Drug Nutrition Interactions website is natural health products and their potential interactions with medications. So if you look at the top of the list, the one that comes up most often in our website is St. John's wort.
Yes.
So St. John's wort is a herbal product that's been around for hundreds of years. It actually is an evidence-based, effective treatment for depression. Turns out it's a weak, what we call monoamine oxidase inhibitor, or MAO, that has some action that is antidepressant-like. And the problem is that when you combine it with other drugs that have similar action or that raise blood levels of brain levels of serotonin, that can lead to serotonin overload or serotonin syndrome in some cases. So there's that aspect of it.
So it makes you too happy? Sorry.
If you call diarrhea, muscle twitching, severe mental status changes, and at the worst case scenario, muscle breakdown and kidney failure happy, then yes. No. So serotonin syndrome can be.
Oh man.
Serotonin syndrome can be quite severe, potentially. Yes. Like most people would experience a milder form of those, but it can lead to serotonin syndrome. And then it's also an enzyme inducer. So sort of the opposite of grapefruit. It speeds up the action of liver enzymes that metabolize drugs, and it can lead to them becoming less effective or completely not effective. And so many products, again, going through that same enzyme. Remember I mentioned the CYP3A4 system? Yeah. Well, it's the same thing for drugs that go through that enzyme system. When they're being metabolized, we would say to avoid St. John's wort typically with those drugs because it will make them work less well.
Oh, work less well, less effective.
Less well, yeah. Less effective. And that can include oral contraceptives sometimes, a lot of different cancer medications. And, you know, if you're trying to cure cancer, you don't want something that can affect the action of your medication. So it's better to just avoid in that case. So there's a lot of warnings with St. John's wort that comes up frequently in our database. Other things like fish oil, can alter the absorption of some drugs. It also has a bit of a blood clotting, anti-clotting effect that can be additive with other drugs that affect blood clotting. And I think
like vitamin E?
Yeah, like vitamin E. Similar idea that it affects platelet function and can be additive with other drugs that affect clotting. And then calcium, certainly calcium supplements are popular. I know you had another podcast I was listening to on the way in today about calcium, and calcium supplementation or in your food can interfere with the absorption of certain medications, some of the antibiotics we use commonly, like tetracyclines or quinolone antibiotics. And they can also affect the action of some heart medications. Again, those calcium channel blockers, they kind of, if you're blocking calcium channels and then you give a large amount of calcium, it kind of opposes the effect of that calcium channel blocker. So there's a caution with calcium supplements as well. But there's many more included in the database. One of the things is there's so many different supplements out there, it can get overwhelming. And so I tried to, in Drug Nutrition Interactions, tried to focus it down to what are the things that are most likely to have an impact or we're most likely to see patients taking that could impact the action of a medication, and sort of limit the warnings to something that's fairly practical.
Yeah, no doubt.
Yeah.
Wow.
What about two questions for you, Dean? What about supplements affecting each other? Is there any danger of bad interactions there? And then things like, I don't know, say like Red Bull, when you're taking, I don't know, a certain supplement or certain medication. I'm guessing that stuff you'd be warned about that when you pick up your medication at the pharmacy. But you know, is there any common stuff like that or that people should be aware of?
So sometimes with the supplements, you can be taking a blend of things that have a mix that is proprietary. You don't exactly know what's in it. There are certainly reports of unlabeled ingredients. So some people will swear by a supplement having this wonderful action, And when they actually go and test it, sometimes they find out it has undisclosed pharmaceutical grade medications in them.
What?
So that has happened. Yeah, that happened with a lot of the erectile dysfunction products.
That's exactly what I was going to say. Yeah.
Yeah, it turns out some of them, when they test them, they contain like prescription ED meds that are undisclosed on the label, and that can lead to very serious problems if you're taking nitrates or other heart medications.
Yeah.
So that can happen. You can have people will take multiple supplements that have similar actions, so you can get more action than you want potentially just through additive effects.
Or get go with calcium. I know that happens with people, and vitamin D, also taking like the multivitamin, plus they're taking the, maybe a big 10,000 because that's what, in long-term care, a lot of times to reduce the polypharmacy and having to give a resident vitamin D every day, they'll do like a 10,000 once a week. But,
okay.
If you because it is fat soluble, so it's got that, it's not like you can't do that with like vitamin C because it's water soluble, but and you like lose it through the day. But with fat soluble, it stays around the system. And then if you're at like the additive, that is such a good point. The additive effect of where you're getting like all the different amounts, like the same with calcium, right? Because there's like you can get a calcium supplement, and then if you have 3 or 4 dairy foods daily, and then you're maybe taking a multivitamin, mineral, and it's just the additive.
Maybe some Tums on top of that.
The Tums, that's a big one. Yeah, exactly. That's right. If you're taking 8 Tums because you have like heartburn, and then all of a sudden you've got like way too much calcium, like way too much, and you might get kidney stones and, all the negative effects of too much mineral in your system.
Yeah, and then try that with a drug that can lead to high calcium levels to begin with. And sometimes people are taking those as well. So you do have to be careful. And that's the role of this website, is to try and provide that information to people who are working with people taking medications. And I know, how many you work in long-term care, like how many medications would you say on average your patients are taking?
On average would be 5.
5, okay. Yeah.
Sometimes 3, sometimes 15,
Yes.
It's crazy,
wow.
Right?
Yeah, exactly. So 5 is about average in the literature as well, and very commonly to see people on 10 or more meds.
Oh, totally.
I think the danger nowadays is there's so much information through YouTube and social media where people are like, oh, I'm taking this combination of blah, 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 and it gives me this certain effect, whatever, weight loss or like you said, ED issues or anything like that. And everyone's like, oh, okay, well, I'll try that. And maybe it does work for one person, but it doesn't mean that it's going to work for everyone. But it seems like people are getting their information from these channels that are unresearched, and there's no background research done into it that sort of prove that it's effective. It makes it dangerous.
There are very few supplements because of the legislation in the US and Canada around these products. You don't, to be able to make certain health claims, you don't need a lot of research backing them up. And so there's a proliferation of products on the market that are this mix of things that in theory might help treat an illness or alter body function. And so these products are able to be on the market because of the legislation that allows it.
Wow. Oh.
And without having to go to the meet the bar of proving that they reduce an illness or reduce an effect or increase an effect or whatever.
Mm-hmm.
And then there's so many different ones. I think our website does a good job with medication interactions with supplements, but for multiple supplement interactions, there's a database called NatMed Pro, which is Natural Medicine's Pro database. And that one is really the comprehensive resource when you're looking at multiple supplements and their potential interactions.
Absolutely. I've been using that for years. Yeah, that's a really good one. Yeah.
That's a good one.
And the other thing, there's a lot of medications that are becoming like over the counter now because people just cannot have access to a doctor or a nurse practitioner that can prescribe. So like you were saying, like PPIs, like the proton pump inhibitors are now, some of them are able to be just over the counter. People can just pick them up off the shelf.
Exactly. And it's especially more so in the US, where there's lack of access to primary care physicians for a lot of people, right? So PPIs, there are available over the counter in Canada as well, and they work extremely well at suppressing acid production. But I saw an article today. It was like easy hello, tough goodbye for PPIs, because it's easy to start them, but very hard to get people off of them.
Totally.
Especially if they're treating like chronic reflux. But they can have nutritional impacts. So they can affect absorption of vitamin B12, absorption of magnesium, and those can lead to clinical problems with long-term use. So those are two of the things we identify that should be monitored when somebody's taking a proton pump inhibitor. But if you're taking it over the counter, you're essentially doing it without that monitoring. And they will say they're intended for short-term use, but we know people do end up using them long-term because they're available.
That's right. It can lead to dementia, like because of B12 deficiency, which it's like it. And, I mean, we're seeing an increase in dementia kind of across the board in North America. And there's so many different reasons and causes and theories, but also like the long-term PPI, where you are not creating the acid to extract, with the intrinsic factor in the stomach to actually get the B12 absorption. Not to mention, as we age, we create less stomach acid. And so we're not doing that as efficiently. But if someone's on the PPI for years, they could have an underlying B12 deficiency, which is irreversible nerve damage and eventually could cause, neurological problems.
Yeah, definitely. So yeah, we talk about like people like, they can't find where the floor is, or they can't really feel the floor anymore. And they think it's neurological, but it could be medication induced and due to B12 deficiency, which is becoming more recognized with the PPIs, as long as magnesium as well.
Wow.
Yeah,
wow. Yeah. It's just, oh my gosh. You're like a walking encyclopedia. It's amazing, all the information, because you've had to like every medication, like you've had to update it, like what it does, how like the mechanism of action, like, wow, it's incredible. Anyways.
I don't remember them all, but this is such a common one. We did start over from scratch. I had done the work with food medication interaction handbooks, but when I did develop this website, I started over from scratch and re-reviewed every medication. We're over 1,100 medications in here now, and we re-reviewed from scratch what the issues are with each one based on their product labeling.
Do you feel like you're constantly chasing the carrot? Do you know what
sense?
I mean? Like, well, in the sense that you're never there. It's always changing. You're always like, you think you've kind of nailed it, and then it changes, and then you got to like do more research. And I mean, I guess it keeps you on your toes and it keeps you learning, and you don't get bored with your work, but it must be a little bit frustrating in some regards. That
that's the fascination, I think. Like that's the fascination with it, that it is constantly changing, although that is sometimes the frustration too. Like, one notable one was the hormone replacement therapy. In the entire medical industry is like, yes, this is a good idea. Let's take the medicines. Here are the benefits and the risks. And then this big study came out called Women's Health Initiative that showed the risks for different cancers and of hormone replacement therapy. And it overnight changed practice, limiting how hormone replacement therapy is prescribed, limiting the duration of use was the recommendation. And it can be very frustrating. Like you've gone down this road for 20 years and then this new study is released and changes the direction almost 180 degrees.
Like clinical practice. Yeah. Oh my gosh. And now it's kind of like there's new, just getting onto that thread, like with the Women's Health Initiative, I think a lot of the women that were studied were like, they started to, have the estrogen, I think it was from, horse urine, right? Like it derived from that, and in their 60s. So it was about 10 years out of like after their last period. So it was actually fairly late that they were introduced to, with the hormone replacement. And it's a little interesting because they, they're kind of like, now there's a lot of information about it could be helpful, but you got to start earlier and like even before menopause, and so it's interesting because there's a lot of healthcare providers have just written it off, saying, nope, it increases risk of breast cancer. There's no way you're going to be able to have hormone replacement therapy. And it's like, well, it's different now, right? Like there's iterations and they've totally, it's now a different ballgame than it used to be.
Yeah, and that's not what Women's Health Initiative said. It said like there's an increased risk. It doesn't mean don't use it, but we were limiting use was kind of the message from it. Limiting use and don't stay on it forever. Pick, depending on your personal risks, if you choose to use it to reduce the menopausal vasomotor symptoms, sometimes that is worthwhile, evidence-based, and can be useful, right? And to not just blanket, never take it under any circumstance.
Exactly.
It's all the nuance. It's all the nuance of when it's useful. So that is changing constantly, and that's the nature of science, and that's kind of the fascination with this area. But it's constantly changing, and you adapt to the new information and incorporate it and try and do the best with that new information for your patients. Yeah.
Yeah. And then when like the blockbuster medications, like when everyone starts using like GLP-1 antagonizers, and now all of a sudden it's like all these people are using it and thinking it's like the miracle cure for, weight loss. And so you got to have your finger on the pulse of that, like that class of medications too, I guess.
Yeah, it's been a big newsmaker. Like I run a news section on the Drug Nutrition Interactions website, and I'd say 75% of the news stories I post are GLP-1 related because it's such a big topic and so many people are adopting use of that class of medications. So it is a big newsmaker, and we're relatively early. Exenatide was the first GLP-1 that came out around 2007. So again, there's your 17-year gap. But the newer, Ozempic, semaglutide, and Mounjaro, tirzepatide are relatively new to the market, and we're still learning about them. We're still learning about how to use them. Conditions beyond diabetes and weight loss that they're looking at, where they may potentially be useful, but also what are the long-term benefits and risks. I still think we don't totally know, do you have to stay on them forever? If so, at the full dose, or is it a reduced, altered dosing regimen, or what actually is needed to prevent regaining weight? And what are the long-term effects? I know you talked about on your other episode, muscle mass loss is something that's of concern, that you have to weigh the risks and benefits for, and we'll learn more. And that's the nature of these medications is you do a short-term study to get your product on the market. You might do 1 or 2 years of follow-up, but then really it's Stage 4 testing is post-marketing testing in the broader population and learning more about what these medications do over the long run.
Oh my gosh. And then the people that do maybe, have been successful with 20 or 30% of their body weight that they've lost on the medication, how is that going to affect other medications they might be on or other things they're doing? Because, we need our lean muscle and, to help with metabolism of medication and nutrients. And what do you have you seen that too?
Not so much yet, but I'm sure they're working on characterizing what those effects are.
Okay.
Yeah, once they're more widespread, I'm sure, right? Yeah. You'll see everything eventually, I guess.
Yeah, totally.
Right.
Yeah. Well, like you see this phenomenon when new medications come out and you read the product monograph, and you're like, okay, this looks pretty clean. And then over time, especially if it's a blockbuster, you get more and more information. The rare side effects that might be, 1 in 10,000 or 1 in 100,000 persons that take it, well, those start to show up when millions of people are taking it. And it becomes apparent over time that, we thought this was no problem, and it looks like this might be a problem. And it becomes apparent later in the medication's lifespan.
Right.
Any
Right.
examples of like really big surprises you guys have, meaning pharmacists and the science side of things, have encountered over the years?
Yeah, when fluoxetine or Prozac launched in the late 80s, it was way fewer side effects compared to the old tricyclic antidepressants. It was thought that it was basically side effect free, and it was thought to be superior to the tricyclic antidepressants for treating depression. And then as time went on, the studies came out to say, no, it's about the same in terms of effectiveness. And with longer term use, some of the adverse effects became apparent. So sexual dysfunction, difficulty stopping, a certain fluoxetine didn't have this issue, but some of the newer SSRIs, the difficulty in getting off of them after long-term use became apparent. Effects on blood clotting, effects on bone and calcium signaling became apparent with long-term use that were not apparent from the short-term trials.
Mm-hmm.
Yeah.
Yeah, interesting.
So now that medication's coming up on 40 years of use, right? And so we have a better picture of it now than we certainly did in the late 80s when it launched.
Right. Wow.
Yeah. Holy. Yeah, that's incredible. Oh my gosh. Oh, wow. This has been so amazing. Lots of information. We could talk for hours, I'm sure.
we probably could talk for hours.
That's right. I swear to God, I think you should do a podcast one day, Dean.
No. All right, well, I'll consult you and Rob on how to do that, Sandra.
We'll just have you as like a monthly guest. Maybe we should have a feature where we have Jean on every month, and we talk specifically about like our interaction with grapefruit. That'd be an issue or an episode, and then because I think that would be of interest to people.
Yeah. Well, because in Canada, people have a pharmacist, a free resource when they go to their, their drugstore or whatever to pick up their medication, and they can get a pharmacist to go over their medications and supplements. And I don't know if people are utilizing that or, and then for healthcare professionals, this drug nutrient interaction database is so robust and comprehensive. It is such a great resource. And literally there are endless topics because medication and, nutrients and food, there's interactions, and it's so interesting that some of these interactions can be quite long-term consequences can happen, right? So it's
yeah, for sure. Yeah. And they can sort of creep up on you kind of insidiously that you think everything's fine. And and for most people, the other thing is you have the medication, you have your nutrition, but what's your individual risk factor? Right. So some people are more predisposed to having these interactions occur than others. And depending on other conditions, other medications you take, even now we're learning more about what we call pharmacogenomics. And some people metabolize or handle medications differently. And there's a genetic basis for that. And that can be a factor in why a drug interaction might occur as well. And
that's
so learning about that.
A whole other episode. I was thinking of that too, because Sandra's been dabbling in nutrigenomics a bit, and I was going to ask if there was a genetic component to this, which I assume there was. And so, yeah, that'd be something else to delve into on one of our special episodes.
Well, just the caffeine too, the liver enzyme that helps clear caffeine. Not everybody has that. And so then caffeine can, build up in the system. You get jittery, you get anxious. Some people actually, it increases their risk of heart attack and stroke. For other people, it could be helpful. It could be actually, reduce their cardiovascular risk. So it's it depends on your genetics. Like you said, it's very personalized, individual. That's why we should have you on the show for a regular spot.
Yeah, so that enzyme, it's another one of those CYP enzymes called CYP1A2.
Yes.
And in the liver, and it is there are genetic differences for whether people's enzyme activity ramps up when there are certain what we call metabolic inducers, and one of the big ones is cigarette smoking, and dried cannabis smoking as well, that can speed up the action of that enzyme. Now, that enzyme not only metabolizes caffeine, but also certain prescription drugs and can speed up the metabolism of certain drugs and make them work less well as well. So it's interesting. It's the dried tobacco, dried cannabis. When you burn them, you create tar. The tar has polycyclic aromatic hydrocarbons that inhibit that enzyme, induce that enzyme and speed it up and make it work more efficiently. That can lead to increased metabolism of both caffeine and certain other drugs. So you may have noticed smokers drink more coffee than non-smokers because their enzyme activity is speeded up by cigarette smoking. What's interesting is, like I said, it's the burning plant material, it's the tar. So people who vape nicotine or use nicotine replacement, it doesn't induce that enzyme activity. It's the burning plant material.
Oh, interesting.
Isn't that fascinating?
It really is, yeah.
And then also people that eat large amounts of barbecued meat, like large amounts, because tar, right? So burning organic material and those polycyclic aromatic hydrocarbons that are in there.
And that would speed up the action of like your liver processing the caffeine. Is that what?
Yeah, that certain enzyme, the CYP1A2, gets sped up and more efficient, processes it more quickly. So you get lower blood levels, lower effects. So people will tend to then consume more caffeine to compensate. But it can also affect the action of certain medications, cause a drug interaction as well.
Wow.
Holy. Isn't that incredible, Rob? Like, oh my God, my head's spinning.
That's so neat.
Certain patients who take a psychiatric medication called clozapine for treatment-resistant schizophrenia, we have to know their smoking status because it affects how we dose the medication. And we provide counseling on, obviously we'd like people to not smoke, but if they do, we need to know so that we can adjust their dosage accordingly to make sure that it works well for them in the face of being a smoker, for example. They would need more medication to get the same effect compared to a non-smoker because of this interaction.
Right.
Yeah, it's super fascinating.
No doubt.
Oh my gosh. Yeah. And back to when you were saying about the cancer medication and how different, there's interactions. And we have, when we talk to patients at the cancer clinic in Victoria about antioxidant medications. So it's okay in food, like it's fine to have blueberries or it's fine to have oranges, that amount of antioxidant in the food is fine. But if they're taking high dose supplements of vitamin C or E or other antioxidants, that can actually almost affect the way the cancer treatment is working in their body. So you're actually reducing the dose of chemo, for instance, with thinking you're helping yourself by protecting your cells, but you can't necessarily protect the cancer cells and not the healthy cells. You know what I mean? So it's like you're protecting all of the cells and that reduces the effectiveness of medication.
Yeah. So it depends how the medication works, right? If it works by generating some of the cancer medications work by generating what we call free radicals. Or essentially oxidants.
Right.
And if you give an antioxidant, it opposes that effect and it could make that particular type of cancer medication less effective. So especially if you're using these certain types of cancer medications with curative intent, we want to make sure that people are not giving them the best chance to work properly, not using antioxidant supplements during the time when they're receiving that cancer treatment to make sure they have the best shot at working for them.
Yes. Oh my gosh. Yeah. Oh my, seriously, we could talk for hours, Dave. Oh my gosh. Okay. We have a question we ask all of our guests that I really wanted to see because I've been listening to you being interviewed other places. So I'm learning a little bit more about that you're a bass player in a band called Bitter Pills. I love that. With the 5 different members, you play the bass, and then there's 3 other pharmacists in the band, eh?
Yeah, that's
awesome.
Right. It's super fun.
You go around Vancouver and play in different gigs.
Yeah, I just did one at the Richmond Night Market this past weekend. Actually, it was great.
nice. Oh my gosh. That's so funny. That's how I met Rob, my husband, is he was a bass player on stage in a band. And I used to be a groupie, like with all of our friends. We'd follow their band around their different venues. And that's how Rob and I met, which is so funny.
Oh, that's awesome. Rob, we'll have to compare notes after about your song catalog. Yeah.
Absolutely. Yeah, that's fun.
It's so awesome. Yeah. So we asked the question, like if you're going to a party or like family gathering or just with friends and family, when going to a potluck, what dish would you bring to share?
Okay. I did think about this.
Dean, I know what you're not going to bring. You're not going to bring a big bowl of grapefruit and citrus fruit, because you know better.
That's funny. In mixed company, you never know what medication they're on. No.
You really want to shake things up.
Put a little label on my dish to avoid with certain medications. Yeah.
True, yeah.
So I did think about this. Every year when we get new pharmacy residents at Children's Hospital, our clinical coordinator hosts a barbecue. And so every year the dish I bring is a deconstructed caprese salad. So I have this big white serving platter, so it looks very nice. And I take alternating layers of sliced Roma tomatoes, sliced fresh mozzarella, and large fresh leaves of basil. And I try and just alternate them. So you get this red, white, and green alternating row. And so I take that and then I put balsamic vinegar glaze over the top. And it's a pretty easy dish to transport and prepare. And it's always the first one to disappear. So that's what I would bring to a potluck.
And that's on a big white platter, right?
Yeah, it looks so good on this big white platter with this.
No doubt.
Seems to be a perennial favorite.
It's
pretty simple. Anything more complicated, my wife Lisa is an amazing chef, and she does some really amazing dishes as well. So I kind of do the appetizer. She does the main course. Yeah. Nice. We make a pretty wicked charcuterie board too, but for a potluck, I'd bring the caprese salad.
Oh, I love that. Oh my God. You had there's a waffle with blueberries. What was that called?
Oh, yeah, it's my neighbor right across the street from her house has this giant stand of blackberry bushes. And so every summer there's fresh blackberries. So I go and pick them in the morning, and then I'll make waffles. And I put a blackberry in, the little dimples in the waffle. I put a blackberry in each dimple. Nice. So I call it the blackberry blackout waffle.
Nice.
I love it.
Having some fun with food. No, that's perfect.
Sounds delicious. Oh my gosh. Holy wow. Well, Rob, do you have any other questions or anything that you were wanting to ask?
No, I really think we should do that caller, the caller questions for Dean though. And we'll maybe when we get some questions, we'll get you back on the show, because I think you're a fantastic resource. And you just know information that nobody else knows. You know what I mean? You've got a very select kind of knowledge base. And I think it's really a good opportunity for people to be able to tap into that from time to time. So
yeah, totally. I'd love to come back and join you for another session and talk about drug nutrition interactions and different supplements and all that good stuff.
That sounds like it'd be a lot of fun.
And I totally encourage people that are listening that are interested, to look up the resource online, the drug nutrient interaction resource that Dean's developed. And it's it's amazing. And the blog articles on there, and just looking up any medication that you're taking or that you're thinking of taking or supplements, you can really get a better handle of any issues there might be or just how they work.
Yeah, for sure. And you probably put a link, I hope, on your podcast page to the website, www.drugnutritioninteractions.com. It is a subscription-based resource. So that's one caveat. It's not wide open. It's a professional resource that does require a subscription to access. So just to note that, so people aren't surprised.
Yeah, and it's very reasonable. $35 a year or something?
I think $39 for Canada, $35 in the US.
Yeah, Oh my gosh, that's incredible. Yeah, just to have that. If you are in clinical practice and you're seeing clients and, just to be able to have that resource at your fingertips is just a great idea for dietitians and other pharmacists and doctors, nurse practitioners. It's just for anyone who is counseling clients, it's a really incredible resource.
Oh, thank you. I appreciate that.
I hope it's not written in that really little font. That's on the prescription bottles, because that's I mean, for me, that's one of the issues is like all the information's right there, but even with my reading glasses on, I still can't see it, and I'm sure I'm not alone. There's just so much information. They got to make the font so small that you can't even read it.
If you load it on your mobile phone or your tablet or your computer, you can zoom it up. So
yeah,
I do that a lot.
Smart tip.
I zoom it up to read it.
Well, we were laughing about that with the eye health, like the lutein, like the supplements that you get for your eye health, and the print is like minuscule, like you can't even see it with glasses on.
I've noticed it recently when I go to a restaurant and the menus are like in mouse type, and yeah, I've had to pull out the reading glasses for that situation more and more.
yeah, it's back to life.
I know. Yeah, exactly. Awesome. Well, thank you so much for joining us this morning on this Friday after morning, I guess it is. And thanks so much. And Dean, we're going to be definitely linking the information in the show notes and getting back to you also to do another show, because I think there's just so much that we could talk about.
Thanks very much. I'd love to come on and talk with you guys again. It's been great to reconnect, Sandra, and great to meet you, Rob.
Yeah.
Love to come back and do this again.
Sounds great, Dean. Thanks so much for joining us.
Thank you. Well, that interview got our wheels turning, about ideas for
Ask the Pharmacist.
Totally.
I love it.
What a great idea for helping people, because this is like such a
complex, I think, and ever-changing kind of issue.
Yeah.
And I'm pretty sure that whatever the question is, Dean will have the answer.
He will.
He's a wealth of information. And it's not just information. I mean, he's got stories that go with it, which is just so much more entertaining to listen to. And it makes you remember things.
Yes.
He's not just spewing information. It's just like, it's useful stuff that he's talking about. So
it just speaks to his experience and expertise in this topic. I mean, he's been doing this for more than 28 years. That's when I met him, and he was doing it before I met him. And yeah, it's incredible all the different avenues that he's worked in terms of pharmacy.
Mm-hmm. Yeah, he's clearly passionate about what he does. So I think that definitely helps him just stay interested after 28 years.
I love that he goes to the dietitian conference in the States.
That's awesome.
Oh, yeah.
I thought that too when he said that. I'm like, oh, that's really cool.
He's been collaborating with dietitians from day one. And I think that is so amazing, because I don't think we can say that about any healthcare professional, that they collaborate with others. And
not too often. Yeah. Makes so much more sense, though. I mean, it should be a team and sharing knowledge, and not like butting heads with each different perspective. It's about the patients or the health of the population, however you're looking at it, and everyone should be sort of aiming towards the same goal.
Yeah, it's a different lens, right? Like you're coming in from a different angle.
Mm-hmm.
And we do resident care conferences for different care homes, and it's always the multidisciplinary team. So you've got the pharmacist and the dietitian and the doctor and the nurse and the family member. And we do this in other settings too. And it's the multi and interdisciplinary team that it's really important to get the different perspectives. And, you learn so much more than just what you're like, staying in your lane is important, but then knowing a little bit about what happens, like with the drug nutrient interactions and supplements and how they all work and how they can affect each other. And
Totally.
It's so complex, as you said, because so many people are taking supplements. Everyone eats, and a lot of people take medication.
Mm-hmm. And I think if we're to sort of draw a bottom line with this whole discussion we had today is just awareness that there are potential issues with different supplements and different nutrients and medications and that sort of thing. And just be aware of that and talk to your pharmacist or your doctor or some health professional that's going to have the knowledge to help you with that. And then Dean's website, I haven't looked at that yet, but that just sounds like another wealth of information that's available to people to, refer to if they need that help.
Yeah, it's www.drugnutritioninteractions.com, and we will have that listed in the show notes along with Dean's contact information.
Yeah, home phone number, that sort of thing. If you have questions late at night and you can't read the pill bottle, just give them a call.
You're so funny.
Yeah, Rob, thanks for that. Appreciate that. And I think we're all serious when we did sort of mention on the show that we wanted to start that series with Dean, like having him back from time to time to answer some questions. So if you have questions, pharmaceutical, drug, medication, nutrition related questions that you think Dean might be able to tackle, let us know. Send us an email.
He can tackle anything.
Well, yeah.
He's a big guy. He plays hockey at night.
In that realm, yeah. Yeah, no doubt.
He plays in a band. The Bitter Pills.
There you go. Yeah, check out the Bitter Pills if you're in Vancouver area. It sounds like it'd be a fun little band.
Vancouver, BC, Canada.
Mm-hmm. Okay, so anyway, send us your questions. You can reach us through our website. It's mywifethedietitian.com, and our email is mywifetherd@gmail.com. So let us know what you're thinking. Let us know what you think of the show, too. That would be great. We love hearing your feedback. Just send us a comment. You can rate and review the show on whatever platform you are using for your podcast listening. You can reach out to us through our social media pages. We're on Facebook, Instagram, and YouTube. Comment there. Send us just a thumbs up is even helpful. Just helps us to know that we're on the right track with what we're talking about every week. So that would be much appreciated. And sharing with a friend is another thing that's also helps the show, helps keep things moving forward here. The more people we get on board, the better. Everyone's going to be healthy, and that's kind of the goal, what we're trying to achieve here. You can also sign up for our newsletter when you're on the website. We've got a weekly newsletter. It's free to join. Lots of great tips in there, weekly updates, recipes, that sort of thing. So check that out when you're on the website. And I think that's it. Anything else there, Sandra?
Well, if you think you can change your health with what you're eating, it's so relevant to look at what medications you're taking and supplements and be aware of the different interactions. So please, if you're taking a supplement or medication and you want to know how it's impacting your health and how your body's working and the food you're eating, send us your question and we will get Dean to answer it.
There you go. Well, thank you so much for tuning in and giving us your time today. And hopefully this episode was helpful. And hopefully we will hear some questions from everyone, because that would be amazing. So we'll be back on Wednesday with Nutrition Nuggets. And in the meantime, have a fantastic week. Thanks for joining us today on My Wife the Dietitian. If you like what you heard, don't be shy. Leave us a comment or review, and be sure to share our podcast with your friends. If you'd like to hear more, hit that subscribe button. You can also follow us on our social media pages for updates, episode trailers, and other odds and ends. For more info and links on what we discussed on today's episode, check the show notes. We'll be back next week with another informative and fun-filled episode.